You probably ended up in the hospital because of your heart failure symptoms. Perhaps you had swelling or difficulty breathing, or maybe you just felt really fatigued and noticed your exercise tolerance was getting worse. Or maybe you've been tracking your weight, like with my daily CHF manager and weekly CHF tracker, and noticed a significant weight gain and your doctor told you to go to the ER. So now you're in the hospital and you want to know what to expect. I'm Danielle, I'm a registered nurse, and I've taken care of many patients in the hospital with cardiac issues, including heart failure. So let me break down for you what a typical hospital stay looks like. First, I'll talk about how long you might be there. This is usually everybody's first question. Then the tests they'll run, the medications you'll get, and other treatments they might suggest. I'll also go over medical terms that you'll probably hear, what day-to-day life in the hospital actually looks like, and what to bring with you, and lastly, what to expect when you're discharged. So how long will you stay in the hospital? This can vary a lot. In a mild case, where your heart failure is otherwise stable and your symptoms are minimal, they might give you IV diuretics in the ER and send you home. This is best case scenario because while the hospital is often necessary, it does come with its own risks. In that situation, you're usually treated under something called observation status, not a full admission. But if your symptoms were bad enough to bring you to the ER, it will likely take more than that to get things under control. Most of the time, you will be admitted to the floor, which means you're staying for a bit. Many stays are around 2 to 4 days, but there are many things that can factor into that timing. It's also very common for people to have multiple comorbidities or more than one issue going on, and these other conditions can definitely extend your stay. Your doctors will run several tests to understand how severe your condition is, rule out other problems, and guide your treatment. Let's talk about them. EKG. This is a quick, non-invasive test with stickers and wires that record your heart rhythm. The doctors will be looking for irregular rhythms that may contribute to your heart failure. Chest X-ray. This is also quick and easy. It's looking for fluid in or around your lungs and changes in the size of your heart that may indicate it's been working too hard. Echocardiogram. Specifically, a transthoracic echocardiogram, usually shortened to echo, which is a non-invasive ultrasound of your heart that's done on the left side of your chest. It looks at your heart valves, shows how well your heart is pumping, and calculates your ejection fraction, or EF. At most hospitals, these are done during the day, and there's often a wait, so don't expect it immediately. Cardiac catheterization. Once you're stable and able to lay flat, your cardiologist may recommend this to look for causes of heart failure, like blocked arteries. It is invasive, but minimally so, and very commonly done. Physicians and other staff may throw around medical terms, forgetting that not everyone in the hospital has a medical degree. So let me go over some words and phrases you'll probably hear and explain what they mean. After your echo, you'll probably hear about your ejection fraction, or the abbreviated form EF. This is the percentage of blood that your heart is pumping out with each beat and helps your cardiologist determine how efficiently your heart is working. You may also hear third spacing. This means fluid is moving out of your blood vessels and into places where it doesn't circulate effectively. When that fluid seeps into your tissues, it causes swelling, also referred to as edema. When the fluid makes its way into the lung tissue, we call it pulmonary edema. And when it is in the pleural space around the lungs, we call it pleural effusions. From your chest X-ray, you might also hear the term infiltrates, which can indicate fluid or other changes. You'll also hear words that refer to your fluid status. Hypervolemia means too much fluid. Hypovolemia means too little fluid. And euvolemia is a Goldilocks of fluid volume, your optimal fluid balance, or your dry weight. Now, medications. The main focus will be on diuretics, commonly referred to as water pills. Extra fluid puts strain on your heart and lungs, so removing it is a priority. You'll likely get these through the IV at first because it is faster and more reliable than pills. It may be given as a push through your IV once or twice a day, or it may be given as a continuous drip. Once your physician is happy with your fluid loss and your labs indicate that your kidneys are still functioning well enough, they'll usually switch to pills for maintenance moving forward. They may also start or adjust other heart failure medications like beta blockers, Entresto, Jardiance, or Farxiga. And if you have an abnormal heart rhythm, you may get antiarrhythmic medications as well. I do have videos that name and explain all of these meds if you want more details on them. There are a few other treatments that your physician may recommend. Supplemental oxygen. You may need it if your levels are low or if you're having trouble breathing. A thoracentesis is a simple procedure that uses a needle and local anesthetic to directly remove the fluid from around your lungs if a significant amount is found on your imaging. And in more resistant cases, if the diuretics aren't working or if your kidneys are too damaged to tolerate them, something called ultrafiltration or aquapheresis may be used to physically filter the fluid from your blood. Now let me walk you through what to expect from your typical day in the hospital. Expect blood work in the ER and then at least once a day, usually very early in the morning, like 3 or 4 a.m. This is so that your doctors can have the results when they round. You will have an attending physician that manages your overall care. If your primary doctor comes to the hospital, they may be assigned as your attending physician. If they don't, then you'll have a hospitalist. You may also see specialists like cardiology or nephrology that will guide more specific pieces of your care. All of these doctors may order additional tests or lab work, which may require additional blood draws. I'll do another video on what labs they're specifically looking at, like your BMP, and what they mean if you're interested in those specifics. Now you'll have at least one IV at all times for medications. And sometimes the nurses can draw blood from it initially, but many hospitals avoid using IVs for repeated blood draws. So this is fair warning that you may be poked a lot. You may also have telemetry, which is a monitor that continuously tracks your heart rhythm, kind of like a mini EKG. And vitals are usually taken every 4 to 8 hours. You'll also have your weight taken every morning. This is a really important indicator of your process. Your team is looking for a downward trend as you lose excess fluid. And just like your labs, the doctors will want the data when they look at your chart, so you might be woken up early for it. They'll also track your intake and output. You might hear it shortened to I's and O's. This means they'll record everything you drink and they'll measure your urine. The goal is to have a negative balance, getting rid of more fluid than you're taking in. That's how they know that the diuretics are working. You may also have fluid and sodium restrictions to help your body get rid of the excess fluid more effectively. I suggest that you keep track of how much you're drinking. It helps the team keep your I's and O's accurate and allows you to practice managing your fluid restriction yourself in case your doctor recommends continuing it at home. I used to draw boxes on the whiteboard to represent each cup my patients were restricted to for the 24-hour period, and then mark them off with each drink to have a visual that everyone can follow. You may also have compression devices called SCDs on your legs or receive small injections in your belly. Both of these are to prevent blood clots. You may also see a respiratory therapist, especially if you use CPAP or need breathing treatments. Please note that even though hospitals tout rest and quiet for healing, and staff will do their best not to disturb you, interruptions should be expected and you'll likely be woken up at least once or twice during the night. Sleeping aids are usually available upon request. Also, orders, labs, and tests may be added or changed at any given time, and scheduling is often predictable. So, as a nurse, I gently remind you to be patient. This is what I suggest you bring with you to the hospital: your ID and insurance, a list of your medications or the bottles, your CPAP if you use one, and comfort items like a blanket, headphones, or something to pass the time. The hospital will provide your medications, so don't take anything unless staff gives it to you, and leave valuables at home. After a couple days in the hospital, you'll probably be antsy to leave. So let's talk about how the discharge process works. Your attending physician will likely want all of your specialists to sign off before they consider discharge. But the attending will be the one to make the final call when your condition is stable, usually after make rounds and lay eyes on you. However, even after they say you're going home, it can take time for orders and paperwork, so expect a bit of a delay. And before you leave, a nurse should review all your medications and instructions with you. You might expect that discharge would be the final topic of this video, but there's one more thing I'd like to discuss so you're not surprised if it's brought up when you're almost ready to discharge. Don't assume that you'll be going directly home from the hospital. Depending on your strength and safety, the hospital may agree that home is appropriate, or they may suggest going home with home health care, which means having PT come to your home a few times a week to improve your strength and mobility. A third option they may recommend is for you to go to a short-term rehab facility for a more intense PT regimen to regain some strength sufficiently before returning to your previous living environment. Some patients may also be referred to a cardiac rehab, which is a supervised outpatient program that helps you safely build strength, improve your endurance, and better manage your heart failure. Here are some final words. Heart failure is one of the top reasons that people are readmitted to the hospital. So what you do at home really matters. My next video breaks down exactly how to manage this condition at home. I'll link the video and my free trackers in the description to help you stay on top of it. Also, this is what I urge of all my patients. Be an active participant in your care. Ask questions. Ask your nurse what the plan is for the day, which doctors are coming, what your labs mean, what medications you're getting and why, and how your weight is trending. Ask your doctors for clarification if there's something you don't understand. Ask your care manager if there are resources to help. And before you leave, ask yourself, do I understand this well enough to manage it at home? If not, what's missing? And if something feels different or worse, speak up early. You know your body best. I hope this video was helpful for you. As a reminder, I do offer one-on-one consults if you'd like more personalized education. You can find the information in the description below. And if this video helped you, the next video in the series breaks down how to manage heart failure at home. If there's a topic you'd like me to cover, let me know in the comments. And don't forget to subscribe to be notified when more clear, practical explanations about heart failure drop.